We have a very exciting and emerging topic to discuss. That's ABO Incompatible liver transplantation. I believe that the donor pool is going to be significantly widened as it is practiced more and more, both on the deceased donor front and especially the living donor front, because you have the opportunity to prepare the recipient well in case of living donor transplantation. So what we're going to do is quickly run over what is known and what there is evidence for in terms of immunomodulation and what happens with ABO incompatible liver transplantation, about 3 or 4 minutes. Then we'll have views from the panel on the controversies. So I'll only touch on what's known. I will not actually talk about protocols. Protocols are for the experts to tell us, and then we will hopefully have some time for audience participation. We know that ABO incompatible liver transplant causes antibody-mediated rejection because of the blood group antigen-specific antibodies in the recipient who does not have that blood group. And unless you're talking about an infant who has a relative B-cell unresponsiveness or tolerance, there is sensitization beyond 1 to 2 years of life, and these patients or recipients basically will have antibody-mediated rejection in milder or severer form unless there is immunomodulation done before the ABO incompatible transplant. And then over 6 to 12 weeks, especially 6 to 12 weeks, but some people say 6 months, there is accommodation. And later on, if the initial post-transplant period is seen through, then they do not reject their grafts. These are the various policies of immunomodulation, and we shall discuss all of them a little bit. First, little bit about antibody-mediated rejection. It basically means that there could be one of the 3 or 4 things: hepatocyte necrosis, which is uncommon in small children; endotheliitis, small and medium-sized; propensity to hepatic artery thrombosis; and intrahepatic biliary complications. The core issue here is that the likelihood of AMR and intrahepatic biliary complications is directly proportional to the level of pre-transplant isoagglutinin. So the whole purpose is to lower the anti-donor antibody levels and keep them low. That's what you have to do. We already know that blood group A2 is less immunogenic compared to A1, and A2 to O grafts fare better. The A to B and the B to A mismatch fares better because the general antibody levels are a bit lower than any of the other groups to O. Splenectomy, which has been one of the ways of immunomodulation, we all know is associated, again, age-related, to various forms of increased incidence of infections. But also, it doesn't get rid of all the B cells. It only has 25% of the lymphoid tissues. So really, it doesn't serve the complete purpose, although temporarily it does bring down the antibody production by about 80%. And then the wonder drug, rituximab, which is the anti-CD20 antibody, which is basically active against cells from the immature B cell stage to the late plasma blast cell stage, but not actually on plasma cells. So in effect, this anti-CD20 antibody acts on B cells and the immediate precursor form of B cells. And for plasma cells, you have to think of using MMF, which of course also acts on B cells. The onset of action of rituximab generally happens in the first week when you see that the counts have actually dropped to almost nothing, and up to a year they are nothing, and then they start to catch up over the next couple of years. This is a study in human renal recipients, which shows that different doses of rituximab have almost the same effect, that between 10 and 15 days, the CD19 positive cells, which are a surrogate marker of CD20 cells, actually fall. So there is a group, including us, that believe that the current recommended doses of 375 milligrams per square meter surface area are probably too high. And you could do with lower doses, somewhere between 35 and 150, because it gives you a good kill of the CD19 and CD20 positive cells. Plasma exchange, there are various methods. It could be filtration, it could be exchange, it could be absorption, and experts will tell us what they prefer. Local infusion therapy. Now, these patients have a propensity to intravascular coagulation or single organ DIC in the liver. So to prevent clotting and thromboembolism in the vessels of the liver, one has given intraportal or intrahepatic arterial infusion of either steroids or PGE1 or methylates. The problem is the complications associated with the portal vein infusion, like portal vein thrombosis and the hepatic arterial insertion in terms of bleeding and thrombosis, happen in about a fourth to a third of the patients, and it's really something that is being given up. Then IVIG, the mechanism of action is that it basically causes FC receptor dependent B cell apoptosis and inhibits complement and T cell mediated graft injury. We all know that ABO incompatible liver transplant immunomodulation before the transplant is associated with a high risk of infections and some dropout of candidates. That means they don't reach transplant, and even if they do post-transplant, they have a higher incidence of infections and sepsis, and in fact sepsis-related death. And then, of course, especially in a country like India, there are cost issues, cost associated with the use of various protocols of immunomodulation, infections, treatment of infections, and of course hospital stay. Then it is also known that in the pre-rituximab era, the difference in survival of ABO incompatible grafts was pretty obvious, obviously different from the ABO identical or compatible grafts. This difference is now dwindling or disappearing with the introduction of rituximab, and similarly, pre-rituximab era, the age-related difference in survival is also pretty clear. As you grow older, you reject ABO incompatible grafts more. But then again, these curves are coming closer together with the introduction of rituximab. There's this data from the UNOS, 1990 to 2006, about 700 odd patients, which again suggests that in younger age group, the survival between ABO matched and mismatched grafts is similar, but in case of adults, the early survival is definitely inferior. So now with this introduction, I'd like to come to the questions for the panel, and would request Professor Fawzi Saliba to give us a little bit about, and I request the panel to keep their answers to about 30-40 seconds, because we have to run through about 15-17 questions. So how would you select your recipients for ABO incompatible transplant?
It depends if you are doing living donor or cadaveric donor. For the meantime, what we did mostly related for acute liver failure patients who this is the most commonest indication. These patients, they do need liver transplantation very urgently, and in some situations we have to accept an ABO incompatibility in the current results. The second indication could be today and could be discussed really HCC patients. HCC patients, I think when we want to consider living donor transplantation could be also a good indication. The last point is on the critically ill cirrhotic patients. These patients now are really high prioritized by the MELD score. So I don't think they could be really indication for these, at least in the countries who are using MELD score.
Right, thank you very much. That's a perspective on the DDLT selection for ABO incompatible transplant. Dr. Sudhindran, I know you've given me some slides. So would you like to tell us what you think about what the age-based protocols for ABO incompatible transplant should be?
Yeah, although we do have the AB antigens in our body, the antibodies are not present at birth. They're actually produced in response or exposure to the same antigens present in the bacteria of the food. So which basically means that at birth, it's not present, and they start forming the antibodies only by about 3 to 5 months of age, and reach the adult level only by about 5 to 10 years. And there is also a thought that these antibody formation may actually decline at the extremes of age. So essentially, as you showed in your slide, with children less than 7 years, they are relatively protected. Definitely less than 3 years, they do not perhaps need all these things that we do in the adults. But when 3 to 7 years, they do have some sort of rejection, but probably we can modify the antibody reducing methods depending on the levels of isogluten that they have. And I think children definitely splenectomy can be avoided because they are the ones who are actually exposed to the immunological problems and infective problems after splenectomy.
Right. Thank you. So basically, young ones may not need rituximab; the older ones do. Coming back to now various types and protocols for immunomodulation, Fauzi, would you tell us, please, what method of plasmapheresis and protocol would you prefer? I know we have a publication from your group earlier on the use of glycosorb.
Yeah, I think we all agree, I think, that the plasmapheresis now is widely used to reduce the antibody titers, either anti-A or anti-B. We are using, and in our paper and the last 5 patients, we are using more selective adsorption of antibodies. Our experience in the past history period in the 1980s and early 1990s was mainly a disaster related to multiple infections in these patients. So we tried to use now the glycosorb, which is really adsorbed selective anti-A. You have colon selective anti-A. Maybe you can show the slides of the adsorbent, the glycosorb. Please, on my slides, if you can show the slide of the glycosorb, maybe not everybody is familiar. There is only one slide with the picture.
Right. I didn't realize that you had a slide.
Sorry. No, he get it, but it's okay.
Can you switch to a presentation which Professor Saliba has given?
Just, I think the glycosorb, we are doing the same. It's a plasmapheresis, but we are restituting all the plasma to the patients. So we are not reducing antibodies. And this is, I think, one of the main points. It is very selective, and we are able to reduce really to very low titer within 1 or 2 sessions the antibodies. This might be an answer to reduce the risk of infectious complication related to the plasma exchange. But sure, we are paying the cost of the
I think we'll carry on with the same presentation.
It's okay.
Sorry, I hope you don't mind. I think it's a little bit difficult to switch to another presentation right now. So I think that point is well taken. Basically, Professor Saliba's group, he and his group believe that part of the reason that you have higher degree of infections is that you get rid of all immunoglobulins, but if you have only removal of antigen-specific immunoglobulins by the glycosorb, maybe the infection rate will be lower. Then, Sudhi, can we have your views again on splenectomy? You started off saying that it should be avoided in young kids. You didn't complete your splenectomy comment.
The basis for splenectomy was that, as you said, it's a site of maturation of B lymphocytes. So if we do a splenectomy, mature B lymphocytes are removed. But now that rituximab has come, that probably takes care of most of the lymphocytes that is there, apart from the mature plasma cells and maybe the stem cells. So, and spleen does have some CD20 negative cells, so which can also be removed by the spleen, which is the basis for the splenectomy. Next slide, please. But then now we know that rituximab has had a major change, and therefore, if you do a splenectomy, the problems, particularly the risk of infections, and the fact that it actually harbors only 25% of the site of maturation. So even if you remove it, 75% of maturation can occur elsewhere in the lymph nodes, etc. And there's no doubt that it does add to the morbidity of surgery. But perhaps it may be indicated in some situations where you may think that this liver is actually small for size, although ideally you should not use it in such situation. And perhaps in patients with hepatitis C, where there may be a reason to start interferons post-op, it may actually maintain the platelet count. But this is a very controversial view. But I think as a rule, most units all over the world has actually given up on splenectomy with the use of rituximab.
Right, so no splenectomy, generally speaking. Now, quickly, Professor Saliba, IVIG, yes, no, when?
I think we have one paper from the literature that they compared they would have better survival with IVIG. That's why I think for the meantime, we need to include all these combination therapies to ensure to have better results.
But would you agree, possibly more for DDLT? if you've got patients of LDLT prepared well in advance, then maybe the need for IVIG will be less.
Probably. I think, like you mentioned also, the main issue is also for T-cell and the mediated rejection. And maybe in the combination of living donor, measuring and taking into account DSA, and if you have high positive or positive DSA, maybe you need to consider more this option of IVIG.
And I will skip local infusion for the lack of time, but what about rituximab? What's the dose you think that we should use for rituximab? Or what do you use?
Well, we are using 375, the
Right.
current dose, because we mostly use it after liver transplantation for treatment. And we have data on a meta-analysis on 9 studies in kidney transplantation. You can use it whenever you suspected rejection, mediated B rejection. So it's good for prophylaxis. We don't know really the dose for prophylaxis. It should be 375 or less, because we also should be aware that rituximab could increase also infections. So,
Sure. Okay. So the standard dose still remains at 375 milligrams per meter square. Sudhi, do you have a differing view?
No, we use the same dose, 370 milligram per meter square.
Right. Dr. Dharmesh Kapoor, what should be, according to you, the immunosuppression protocol for these patients post-transplant?
I must concede that I am the odd one out in this panel. I have never cared for a patient who's undergone an ABO incompatible transplant. I would just like, for the sake of the audience, to know that I have no experience but a slight difference of opinion from what the other speakers have said. Because in deceased donor transplant, if you have to consider ABO incompatible recipients, then probably you have to also consider the titer of the isoagglutinin that is present in the recipient, because with one session of plasmapheresis, you might not be able to remove all the antibodies. And I will also be very averse to look at the hepatitis C indication for patients with incompatible transplants, because here is a situation in which you are bombarding the patient with a lot of immunosuppression, and that might be counterproductive for the graft outcome in the years to come. And from my reading of literature, I did not see too many hepatitis C patients being included in this category of patients. Now, coming to the question that was assigned to me, the studies have shown that you might even use immunosuppression pre-transplant, and some studies have used just mycophenolate mofetil a week prior to transplant, and others have used the triple immunosuppression, including steroids as well as tacrolimus. So tacrolimus is used at a lower dose. You can start 1 week prior to transplant, but by the time the transplant happens, you try to maintain levels, the trough levels of tacrolimus at least 10 to 12 nanograms per mil. The important thing to remember is that these patients are predisposed to antibody-mediated rejection, and therefore you want to have good drug levels on board at the time that they undergo transplant.
So would you think a little higher than the usual matched patient?
Yeah, so I think it would be we should go with the levels rather than a given dose. So by the time the transplant happens, you would opt for, and these are the kind of levels that ordinarily you would look at on 7th to 10th day in the conventional compatible or identical transplants. But here you would want much higher trough levels right at the beginning of the transplant. And then you start with a higher dose of mycophenolate mofetil.
To less than 1 in 16, then they are by and large happy. Perhaps lower for IgM, maybe 1 in 8. Try to maintain the low levels for at least weeks by and large after transplant. Beyond that, it doesn't seem to matter that much, but if there is evidence of rejection later on, then you might want to relook at the levels. And if the titers are high and it seems to be antibody-mediated rejection, then there might be a role for adding plasmapheresis or to treat the rejection at that point.
Right. What's the duration of caution that you have to exercise post-op? I mean, just 2 weeks or longer? I mean,
rejection has
when do you stop worrying?
I don't know if there's a cutoff at which you stop worrying altogether, but rejections, AMR has been reported as long as 3 months after the transplant. But I think by 2 weeks you're ready to discharge the patient, and if the LFTs are holding after that, then you're not that worried about the antibody titers.
Right. Oops. Okay. Right. Can we have the final comments from Professor Saliba again? What about protocols for ALF, ACLF, and DDLT? Would they differ from chronic liver disease patients electively undergoing LDLT? You think there should be any difference?
I think the protocol could be the same, but the indication in the case of is more related for the acute liver failure situation or acute on chronic liver failure situation.
So what I meant was, maybe intensive plasmapheresis for the urgent patients, or more IVIG, or more dose of rituximab, or would it all be the same for both kinds of patients, acute and chronic, and DDLT and LDLT?
Yeah, in these patients, we intensify because we were not able to do reduction of the IgG prior. We are not prepared. So I think in each case now of ALF, we measure the anti-A antibody in case we were facing an ABO incompatible. And if it is high, we'll start immediate plasma exchange immediately after the transplantation. We do also induction therapy, which I think it is more debatable, but I think in these patients, especially the ALF, ACLF, induction therapy could be important because most of the time you have renal failure and you are not able to do optimized immunosuppressive protocol.
Right. So thank you all. Now we'll move on to some questions from the audience. Overall, I think I would summarize saying that, to quote Vinay's title in one of the papers, there is reason for guarded optimism. I mean, obviously it's exciting to be able to use any group donor for any recipient, but one has to select your recipient carefully and prepare them carefully with immunomodulation and be on the lookout for increased incidence of infections post-transplant and trying to maintain low isoagglutinin levels perioperatively. So I think that kind of sums up, and all this requirement varies between children and adults. Children are easier to manage in ABO incompatible liver transplant protocols. So with that final comment, questions are welcome from the floor.
Just ask one question. In DDLT cases, what is the timeline in using these therapies? Because there's not much time when the organ comes.
So Professor Saliba, I think you should take that. When do you start and what do you do?
No, in deceased donor, the only indication we are using is for acute liver failure. So this is what I said. You need to, in each case of acute liver failure, you need to, within the screening you are doing for etiology, we measure the antibodies, anti-A, anti-B, in case we are facing. And we do quadruple immunosuppression regimen, including induction therapy, and we will start plasma exchange immediately according to the titers, like we say, in order to reduce titer to below 116. That means to remain 1.8. One point I want just to add, we have now data, long-term data, 3-4 years data. These titers will remain low even 3-4 years after the anti-A antibody, even undetectable or extremely low within 1 month, and remain 3 years after. If you measure them, you will still stay undetectable.
So basically, if you sorted them for a month, they are going to be okay.
Yes, absolutely.
Yeah.
This question is again for Professor Saliba. I just want to know what's the induction agent you're using, and if you have any experience with use of anti-plasma cell therapies.
No, we are using induction. We used initially, you can use either the thymoglobin ATG, but only for 3 to 4 days, otherwise the risk of infection increase. We are more using anti-CD25, basiliximab, in this patient.
If there's any burning question, quick, short one. Okay, we're already running out of time, and I think people are running out of patience because they want to have food. So thank you all very much, and over to you, Prashant.